medical, everything. Brad Korn is with us this evening. Brad?
Hello.
Okay.
I'm not I'm clearly not the important one here tonight. Joshua is going to speak tonight on screenings and two different types thing, and he is an important researcher with our Cancer Institute, and I appreciate his time. As you know, I'm always here to help and try to do what I can, but our medical experts and the people who give service are the ones who are the true people who are the most important. So I just want to thank Joshua for doing this tonight.
We thank Brad for arranging it for us, for facilitating this, as he has done many times in the near and long past, and we much appreciate it. Joshua, who was just mentioned, is the clinical research coordinator and health educator for Mount Sinai Icahn School of Medicine, and specifically to the Tisch Cancer Institute. And we appreciate not only your time and expertise, but sharing the current information, because I know that that institute really is in the forefront, and we're thrilled to have you this evening. And
thank you. Yeah, what an honor to be invited to be speaking about this wonderful topic that much needed for updated information. Yeah.
Okay, so we can start as soon as you're ready. Do you want to share a screen?
Yes, I'll share my screen. So yes, let's see. Can everybody see? Is that showing up correctly for everyone?
Excellent. Thank you.
Great. Yes. So hi, everyone. My name is Joshua. Thank you for the introduction before, also by Brad as well. Yes, I'm I work with Mount Sinai Tisch Cancer Institute, specifically regarding about just cancer education. So we do outreach to different community, and honored today that we're at Community Board 7 to just to provide some updated information, or some general information for breast cancer as well as prostate cancer. So we'll get to that later on. So let's get started with breast cancer.
Okay,
shall we?
If I may interrupt.
Yeah.
It happens to also be, and one of the reasons for breast cancer, although the interest was there, this is Breast Cancer Awareness Month.
Yes, it is but it is the tail end of Breast Cancer Awareness Month, but nonetheless, still Breast Cancer Awareness Month. All right. So yes. So our goals today for this presentation is to, of course, increase participation in breast cancer screening. That's what we aim for the community to do, as we encourage more people to do the screening, right? To educate the community about breast cancer, just for those who might not heard of it or have outdated information or things like that, right? Also to share resources for breast cancer screening, and just to overall, our main goal is to get more women or persons with a breast to do their annual screening or annual mammograms. So statistically, about 1 in 8 women will be diagnosed with breast cancer in their lifetime. So it's pretty significant. So I just think about it, just statistically, 1 in 8 of women you know in your life, they will be diagnosed with breast cancer. So it's a pretty significant condition that affects a lot of the people around us. So in 2022, it's estimated because with variations of reporting, slight variations, but about 339,000 women are diagnosed with breast cancer alone, new diagnosis in the United States, just in 2022. So you can see that it's a large amount of people that's affected by this. And just some data, right, across race and ethnicity, we can see that breast cancer does not really discriminate. It's pretty even across the board. We do see slightly higher in the African American as well as the whites, but across the board it's pretty average. Everyone is similarly affected by this condition. But one thing of note, though, is that African Americans are disproportionately affected in terms of mortality rate by breast cancer. So one main focus is that we try to get more people to do screening. If we catch it early, then we might be able to do something to help with the mortality rate. And so just something of note that we do notice that African Americans are disproportionately affected by this breast cancer compared to the other races and ethnicity. Okay, now this is a data on the mammogram screening rates based on 2018. So it's still not the most recent, because the most recent data, they're not I guess studied well enough or collaborated enough that we can give like a chart like this. But as of the most updated information that we have available, this is our screening rate across the country. So we can see that, okay, we're doing pretty well, of course. We aim to be at above 80. Of course, if we can do 100%, that's the best. But we are getting at least about half, 50, 60%, close to 70 on some of the ethnicities. But we do see that at the final column, we see that uninsured population are much, much lower in terms of screening rates. And it could be due to a number of reasons. And hopefully through this presentation, we can hope to address some of that issue. Okay, so just a short recap of what we know so far. 1 in 8 women will be diagnosed with breast cancer in their lifetime. Both men and women can get breast cancer. However, male breast cancer is a slightly, well, it's not slightly, it's a different condition compared to a female breast cancer. So not too much information are known so far in terms of, because it's such a rare case that there are still studies going on in terms of for men breast cancer. Okay, and breast cancer risks differ by race, and also mortality differs by race. But there are plenty of ways to lower your risk. And main point, as you see highlighted in blue, finding cancer early can save your life. This is one of the main focus that we're trying to do. We hope to promote screening so that the early detection, the earlier that we can detect cancer, the more options and the higher survivorship of the condition. Okay, so some of the concerns, common concerns and myths about breast cancer and screening mammogram. You know, some individuals might not know what breast cancer is, or some individual may not know what cancer is in general. Now, what is cancer? Cancer is, in layman's term, it's basically when our cells in our body grow uncontrollably. That's in essence what cancer is. Of course, many medical jargons and many details goes into that, but in overall, in a sense, that's basically what cancer is. It's our uncontrolled cell growth of the body, because cells, our body is made out of cells. So cancer can occur in anywhere in our body. And now, because on the subject of breast cancer, we do need to talk about a little bit of breast. Mainly 3 main parts that makes up the breast. One is what we call the lobes. These are the section of the tissues that produce milk. They are also made up of smaller parts called the lobules, but in general, these are the organs, or these are the tissue that creates milk when a female or when a woman is when they're producing milk. Now, ducts are these tiny tubes that carries the milk from the lobes to the nipple. And then, of course, there's connecting tissues holding the breast together. For example, you have muscles, you have fat, you have your skin tissues, you have everything that holds the breast together. That we call the connective tissue. Now, most cancer begins in ducts or the lobes, meaning that some people might ask, or some people might say that, oh, I have a larger breast, I have a smaller breast. Would that affect the risk factor of getting a breast cancer? We can say pretty definitely that it does not matter your breast size. As long as you have ducts, as long as you have lobes, you have this risk of getting breast cancer, just as anyone else. Of course, some people might have more ducts, some people might have more lobes. For those cases, then they do have a higher risk, because there's just more cells for them to have the condition in, right? Breast density, just tying into a little bit of what I just said. Some people, some ethnicities, some races have naturally more dense breasts, meaning they have more of the ducts, more of the lobes versus fatty tissues. So those with denser breasts are at a high risk for breast cancer. And we know that right now, usually African Americans, as well as Asian women, they do have denser breasts compared to the other ethnicities. So they do have a higher risk of breast cancer, just slightly. And then about 10% of women have extremely dense breasts. Now we can see with the picture there that normally you can see that A would be a very breast that's very high in fatty tissue, where we really don't see any of the denser cells or the tissues. You can see B that's scattered, where you would see some fatty tissue, but you can see also the other cells. Now C would be a something that we would normally see, where it's where everything is distributed evenly, and we can see the cells as well. We can know that the fatty tissues are evenly distributed, and we can see D are extremely dense breasts, where it's just a big lump of tissue, sometimes very difficult to distinguish what's what through a mammogram. Now, what's breast cancer? Breast cancer is just basically cancer that develops in the breast, as mentioned, usually in the ducts or the lobes. Some pictures you can see that right here on the left, you see that's a clump of cells. Of course, with a untrained eye, we can't really tell the difference. Like that just looks the same as anything else. But of course, to a trained professional eye, it would be something of alert that they should look more into. It's supposed to be a PowerPoint, so that myth is supposed to slide up, but that says I maintain a healthy lifestyle, so I won't get breast cancer. So that is a myth. Yes, although a healthy lifestyle does decrease your risk of getting cancer in general, such as a diet of low fat and high fiber, right? Or exercising, keeping a healthy weight, limit alcohol consumption. We all love a drink here or there after work or when we're with our friends, but limit our alcohol consumption, right? Or limit exposure to carcinogens. We know one big thing is smoking. Smoking is a main contributor to cancer in general, all across the board. So, do not smoke. Try not to smoke. But having said that, even if you maintain a healthy lifestyle, you're not totally completely immune to cancer. Even if you do everything right, you can still get breast cancer. All right. So that's why early detection gives you the best chance of beating the disease. This says, I don't have a family history of breast cancer, so I am safe. That is also a myth. Some individual might hear that cancer runs in the family. While it does kind of runs in the family, because genetic does have a play into your risk factors of getting cancer, we can see that statistically about 80 to 85% of persons diagnosed with breast cancer are actually the first in their family, meaning that they don't have any other in their family that gets breast cancer, that has breast cancer. So although family history is a part of it, it doesn't mean that if you don't have any family history, you're safe. Once again, some statistics proving that. Okay, so family history, genetics plays a factor in contributing to the chances of getting breast cancer. However, two main things that we can't control. One is being a woman or being a person with a breast, as well as getting older. That's something that we can't control, right? As time goes on, we all get older. So these two would be the most important risk factor for breast cancer that we have no control of. This says, I'm not over 50 years old, so I don't need a mammogram. Now, as of currently, our guideline for breast cancer screening starts at age 40. That's the current most up-to-date guideline. So some facts is that 1 in 5 breast cancer occurs in women younger than 50 years old. And then women younger than 50 years old are at a high risk of developing triple negative breast cancer. What that is normally, usually breast cancer, we can detect breast cancer by also detecting a type of protein or antibody in that person's body. Now, there's 3 main types of antibodies that we could look for. However, with triple negative, they all come out as negative. So with tests, sometimes for these triple negative breast cancer, we can't detect it just by blood work or just by doing these tests. We have to find out through a mammogram or other imaging tools. But so these are more prevalent in women younger than 50. Now, mammograms does is very helpful. It does reduce the rate of women in their 40s as a result dying from breast cancer by up to 29-30%, right? So it's a main tool that helps us reduce the mortality rate of women dying because of breast cancer. So as I mentioned, current standard guideline, mammogram starting at age 40, right? So if you're approaching the age 40, or you know someone that's approaching the age of 40, or you yourself are at age 40 or beyond, but you have not done your mammogram screening yet, be proactive about your health. Ask questions, ask your healthcare provider. Make sure that you're asking where I can get screening, where should I do start screening, and things like that. All right, this is for the gentlemen. Men, I don't have breasts, so I cannot be affected by breast cancer. 1 in 833 breast cancer does occur in men. So careful at that. It's 1 in 833 breast cancer, not 8 in 100, not 1 in 833 men. So of the 833 breast cancer incidents, there's 1 of them for men. So we can see that it's comparatively much more rare for men than women. However, it is for men, it is commonly diagnosed at a later stage because probably due to the poor awareness of disease, or just many men not knowing that they could get breast cancer, of the fact that they could also be affected by breast cancer. So hopefully increasing awareness for the risk factors for breast cancer, as well as signs and symptoms, can reduce these later stage diagnosis of men. So once again, early detection is key. Now, what causes male breast cancer? As I mentioned, because it's such a rare case that not a lot of data or not a lot of statistics are out there, so that we can make a good education or a good factual statement for it yet. But just know that it's out there, so it's possible. Right? We're still doing studying, we're still conducting research about this. Okay, but one thing that we do know, many things that we do know, is genetics. As I mentioned, family history, genetics does play a big part. Notably, the BRCA2 gene. Some of you may be up to date about what BRCA2 gene is, or don't know what that is. It's a specific gene that we could actually test for mutation, and then that would in turn tell you if you're at risk for breast cancer or not. So it's a very useful tool that we could look into. So genetics, right? Family history, that's also a risk factor, especially if you have first or second degree relatives of both sexes. So first degree relatives, meaning your direct relatives, your parents or your children, right? Second degree would be your cousin or just one off, right? Age, as mentioned, as we get older, the higher chance of getting cancer, just all types of cancer, not just breast cancer specifically, but as we get older, just more, we're at a high risk. Obesity, or any condition that causes changes in estrogen. So for any medical condition that changes your hormone level, especially estrogen, the higher or lower, right? Any changes in estrogen might cause a higher risk, as well as transitioning, transgender women, or radiation, right? And we know that breast cancer are more common in African Americans, and male breast cancer are more common in African American and Jewish men. So they are the population that's effectively higher by male breast cancer. Okay, so this says I perform breast self-examination and I don't feel anything, so I don't need a mammogram. All right, so we will talk a little bit about what breast self-examination is. So that's something that we encourage all ladies or women with a person with a breast to do, that you do from time to time, look into the mirror and just check and just look at your own breast to make sure that there's no abnormal signs or sorry, just stuttering. So any abnormal signs or any weird discharges or itchy or any abnormalities with your breast, because you know your own body best. So if you notice anything that's different, that's something that you should be aware of, right? So something such as a lump or hard knot, or a change in the size of the shape of the breast, right? Sometimes you might have nipple discharge or a pain in a spot that does not go away. We understand that sometimes through a lady's menstrual cycle, some of these changes might be present. But if you know that sense that's something outside of your normal, then you should be proactive and find out what's wrong, right? So if it's, once again, if something it's outside of your normal, find out what's wrong. Okay. Some individuals might say that if I don't feel sick, why should I go looking for sickness, right? That might be a mentality of an older generation, right? Saying that, oh, I don't feel sick, so I shouldn't go looking for a sickness or disease, right? But however, one fact that we stress over and over again, early detection is key, right? So the best time to diagnose breast cancer is when symptoms have not yet appeared, right? When it's not really showing any signs, when it's not affecting your body yet, that's the best time to find out if you have cancer or breast cancer or not, right? So we divide breast cancer in different stages, right? In the earliest stages, in stage 0 and stage 1, right? These are what this means is that the cancer cells are confined to a very limited area where it originally developed, meaning that it's still just at an early stage. It has not spread to other parts of your body yet, or has not spread to the other part of the breast yet. At this stage, screening mammograms can find these tumors, these cancer cells, and it's most effective then, right? About 99.1. So 99% of women diagnosed with breast cancer at stage 0 or 1, so the earliest stages, will survive and thrive with no issue whatsoever, right? So as long as they diagnose it, they find out and they treat it, or find ways to treat it, then they can survive and thrive with no issue whatsoever. Of course, there's always risk of the cancer coming back, but as far as that cancer cell in the body at that time, those are done. However, if we're not diligent with our breast exam and we're not doing our mammograms annually, we might not find it, we might not feel it, right? Then it might grow into stage 2 and stage 3. Now, stage 2 is when the tumor is growing, but it's still contained within the breast, or at some cases, it spreads to nearby lymph nodes, right? And stage 3, meaning that the cancer cells has already invaded the surrounding tissues near the breast. Now, in these cases, while it's still treatable, the survivorship does decrease. So about 86%, right? Would after treatment would live at least 5 years or more, right? So from a 99, we're dropped to 86. So you notice once we let the cancer grow, our survivorship chances drops. Now, if the worst case scenario, right, we don't do anything and our cancer develops into stage 4, right, meaning that it has spread beyond the breast and to other areas of the body. Now you notice that it's only 30% of women with stage 4 will survive 5 years beyond diagnosis. So 30% will survive 5 years beyond diagnosis, meaning that 70% will not survive 5 years beyond diagnosis, right? So that's a big drop in survivorship, right? From 99 to 86 now to only 30. So that's why it's so important to be detecting your breast cancer, or as a matter of fact, all types of cancer, the earliest, soonest we can, because the later we leave it, the less chance we have to survive. But good thing is because we are, as a whole, we are doing our screening relatively diligently. So about 90% of people diagnosed with cancer does live for 5 years or longer. So it's not like a death sentence, not a grim tale that we have to, once we hear breast cancer, oh no, right? There are some positive news that 90% of people do survive 5 years or longer, right? Due to medical advances and all these new methods of detecting and treating cancer. Okay, so now I'm interested in getting cancer screening, but I don't know what it is, right? So some people might not know what a mammogram is for the younger ladies, right? So a mammogram is basically X-ray picture of the breast, right? So it detects breast cancer cells before they can be felt. And so it's a machine that takes picture of the breast. Now, some people might say X-ray, isn't that a radiation? Won't that give me cancer, right? Now, with current medical advances, the radiation exposure for a mammogram is so low that's comparable as taking a flight, right? So, and you do mammogram once a year. So just think of this as taking a flight maybe to LA for a vacation or to Florida for a summer vacation, right? So that's the same amount of exposure of radiation exposure that you would get from a mammogram. So it's basically next to none, and that does not impact your risk of getting breast cancer from a mammogram, right? Now, for those who have experienced it before, mammograms were painful, and I'm scared. Yes, mammograms are painful because basically what they do is they will have two metal plates, and that basically press down on the breast and compress it so that they can take a picture of the breast. Now, this can be uncomfortable for those who have experienced it. Everyone tells me it's painful. I have not experienced it myself, so I can't tell from a firsthand experience, from a firsthand account. But many ladies have told me that it's very painful. And however, it's a necessary pain because the technician do need to compress the breast to get a clear picture. Hopefully they can do it in one go, right? The whole process takes about a minute at most. So just endure the pain for a minute. Normally it's just about 20 seconds, but I'm giving a minute just to be on the safe side, right? So it takes about a minute or so. And so I compress and get a picture of the breast, both left and right. So they want to do it in one go so that you don't have to undo the pain again if they don't get a clear picture. So that's basically what a mammogram is. So your breast will be pressed between two metal plates, and it will take a picture of X-ray picture of the breast. Now, to reduce discomfort and pain, of course, do not schedule your mammogram when you're about to have your menstrual period, because we know that breasts are your breast will be very tender then. So schedule it after this, right? Or if it's still too painful, tell the technician. They may or may not be able to adjust to make it less painful, but hey, that doesn't hurt to tell them that, oh, it's hurting too much for me. Can you lessen it? Can you just, be more gentle? Sometimes they might be able to do it and still get a clear picture. Now, of these scans, sometimes there might be these, what we call the benign breast conditions. So after you do a scan, after they take a look at the X-ray, they might see that some lumps are present in the breast. So don't freak out yet. Do not immediately think that, oh no, I have breast cancer. Because many times, about 80 to 85% of the times, these benign breast conditions, these lumps are non-cancerous, right? So don't freak out, don't panic and go, oh no, I have breast cancer right away. Make sure, talk to your technician, talk to the doctor, make sure, hey, what are these? Can I find out more? So sometimes you might need additional testing, such as ultrasound or MRI or biopsy, to figure out what these benign breast condition is, or they can tell if it will turn cancerous or not, right? So we might need to do extra tests, additional tests to make sure, right? But there are times that you might see lumps or these growths, and it's not cancerous. So do not panic right away. Now, this says, I'm not confident that I can pay for my screening mammogram, right? So recall in one of the beginning slides, we say that the uninsured population has a much lower screening rates. And that's one of the factors that plays into it, that they don't have the financial means to pay for a screening, or they don't know if they need to pay for the screening or not, right? So that's one thing that we also need to address with our community, right? So a few legislations. First of all, the U.S. Affordable Care Act, right? So that requires insurers to cover breast cancer mammogram screening every 1 to 2 years for women over 40 without charging co-payments or co-insurance. So as long as you have insurance, this will ensure that your breast cancer screening will be covered for you for free. No co-payment, no co-insurance. All right, this is true even if you have not met your yearly deductible, right? So that's a good thing to know. that if you have insurance and you're a woman, that your breast cancer screening mammogram, pay attention, screening mammogram of every year or every 2 years will be covered for you. Now, specifically for New York State, in 2016, Governor Cuomo did sign a law that prohibits insurers in New York from requiring cost sharing for women who need breast cancer screening and diagnostic imaging. So meaning that maybe MRI and ultrasound, these types of diagnostic imaging, right? So meaning that insurers cannot apply services against annual deductibles and also cannot charge co-payments or co-insurance for such services. So meaning that, once again, as long as you have insurance, you should be covered free of charge because they are not allowed to charge you for co-payments or co-insurance. Now, for those who do not have insurance or have health insurance that does not cover screening, right? Or you have this option. This is what we call the Cancer Service Program, right? This is the New York State Department of Health that's in charge of this. Basically, this provides breast, cervical, and colorectal cancer screening at no cost to women and men who are meeting these criteria first, no health insurance or have health insurance that does not cover screening, meet the age requirement for breast cancer, we're saying 40, right? And as well as living in New York State. So as long as you have proof that you live in New York State, you're age 40, and you have no health insurance or you have health insurance that doesn't cover screening, you can call this number, right? This at the bottom, 442-2262. You can find out which hospital, which clinics, which health centers, which doctors near you participate in this program, and you can get your free screening. So free of charge as long as you fulfill these requirements. So, mammogram and clinical breast exam, age 40 or older. So we do, so some programs do only serve women age 50 or older because they're not following the most updated guideline. So they're still with the age 50 guideline, but call this number, find out what's near you that can give you that screening. So 442-2262, it's called the New York Cancer Service Program. Okay, so now I know what a mammogram is. How should I prepare for a mammogram, right? I mentioned that, hopefully you can do this in one go and not go back or do a second time. All right, so one very important thing is this: before you do the mammogram, do not use deodorant, do not use lotion, do not use powder, do not use perfume. Meaning that don't put any other substances on your skin before you do the mammogram. You can do it afterwards. That's not an issue. You don't want anything else to be on your skin before you do the mammogram so that the picture can be clear and everything will show up properly. Versus if you have lotion, it might be a smudge, right? We don't want that. Also think about your family history. So if you're going for your mammogram for the first time ever, tell your technician, tell your doctor about your family history, right? My aunt or my mother has a history of breast cancer, so they can be aware of it, of the higher risk that you might have, right? Or if you have prior mammograms done. Nowadays, it's easier because everything is online, everything is electronic. So my chart or other things like that, where your past results will be on there. But for people who do have physical copies of their mammogram, like a film or a CD, you can bring them with you to your technician, to your doctor, so that they can have something to compare, right? Let's say 5 years ago, your breast looks like this. Now your breast looks like this. They have something to compare. Okay, now after your mammogram, usually it takes about 2 weeks to get a result. If you don't get your results after 2 weeks, call. Be proactive about your health. Find out what's taking so long. Find out from your doctor. Find out from the lab that's doing your screening. What's taking so long? Usually it takes about 2 weeks. What's the report tell us? Basically tell us two things. One is you have no signs of breast cancer. You're safe. Come back next year. Or they might find something of note that they might need additional imaging to make sure what that is that they found, right? Something such as ultrasound, a diagnostic mammogram, an MRI, or biopsy, right? So hopefully for the ladies or for any person with a breast of age 40, have you done your screening mammograms yet for this year? If not, don't be shy and schedule it for the year. It's October. We know it's the end of the year, but don't skip out. Do it every year. Okay, so some additional resources, right? Once again, this number 442-2262, that's the Cancer Service Program for New York State. So that's a number that you can copy down. You can take a picture or whatever helps you. That's something that's a resource that you can call to and find out more. Yeah. If you have any questions, you can also contact us. This is our team. Our number is 824-7802. And yeah, so I'll leave the questions towards the end because I still need to go into prostate cancer. So just give me a second while I jump into the prostate cancer slides, okay? All right. I know it's a lot of information. Hopefully, everyone is digesting everything I've said. So if you have any questions, feel free to ask me at the end of the presentation. So now I'll jump into prostate cancer. So prostate cancer awareness and detection. Of course, same thing. Our goal is to promote awareness, promote screening. So now this is to educate men about prostate cancer. So fortunately enough, well, women cannot get prostate cancer because prostate, it's an organ that only the male has. So ladies, although this doesn't concern you personally, it definitely concerns the men of your life. So you can still listen and learn a thing about prostate cancer. Hopefully through you, the men in your life could learn a thing or two or be helped by what you have learned today. Of course, to increase participation in prostate cancer screening, also to share resources for cancer screening within the community. So same goal, basically, essentially, right? So what's the prostate gland? Prostate gland is an organ in the male reproductive system. So if on a picture, we can see that it's just right below the bladder. So that's the cavity that holds our urine. Sorry, and prostate sits right below that. Right, and it's in front, right? It's about approximately right in front of the rectum. So that's the end portion of our large intestine, right? So what the prostate does is it makes a fluid that constitute to, of course, combining with sperm that makes the semen fluid, right? So it's a organ that's in our reproductive system, right? So you can see that it's like a triangular shape. Kind of little organ, right, sitting right there. Right. So what's prostate cancer? Right. As we mentioned before, cancer. Right. It's just abnormal growth of cell, and if it begins in the prostate, as the name suggests, then we call it prostate cancer. Right. So it could grow at any part of the prostate, but normally, actually, most of the time, it grows in from that if you can see from the picture, it's mainly split into 3 sections, right? So the prostate gland is split into 3 sections, and a majority of the time, the cancer would, for whatever reason, begin at the I guess at the lower back portion of the gland, right? If you would describe it that way. So that's what this picture is showing. Most of the time, it actually begins there. Right, so some facts about prostate cancer, right? Goes with some statistics. Prostate cancer is the second leading cause for cancer-related death in men. About 1 in every 8 men will be diagnosed with prostate cancer during lifetime. So you see a parallel. Prostate cancer and breast cancer, they are equally significant in terms of affecting their respective population. So prostate, 1 in 8 men, breast cancer, 1 in 8 women. In 2021, it's still a very, very large number, 248,000, not 24, 248,000 men were diagnosed with prostate cancer in 2021 alone. Now, one sign of relief is that prostate cancer is a relatively slow growing disease. And why that is significant, I will go into that a little bit later, but just know that prostate cancer, more men, okay, how should I phrase this? More men would die with prostate cancer than die by prostate cancer. If you're catching what I'm trying to say, right? So prostate cancer is a slow growing disease. New cases of prostate cancer by race. This is also unfortunately disproportionately affecting the African American population higher as well. So we can see that all races is about 111 per 200 cases. It should be that's okay. So but in essence, we're seeing that the African American men are disproportionately affected by prostate cancer by quite a big margin compared to the other races. Similarly, mortality rate also, African Americans are disproportionately affected by this cancer type than the other races. It's double, almost double, right? Now, survival rates of prostate cancer, meaning, as I mentioned before, prostate cancer, it's a slow growing disease. 5 years being diagnosed with prostate 5 years or more still has about 98% of survival rate, right? So the first localized, regional, distant, basically that's another way of saying what stage of cancer you what stage of the cancer. So 0, 1, 2, we would call that localized, right? 3, we would call that regional, and 4 will be distant. So of course, with distant, it's still a dramatic drop in survivorship, but we can see that in localized and regional, even in 1, 2, or 3 stage of prostate cancer, survivorship for 5 years is still at 100%. So meaning that you don't really have any issues with prostate cancer at the earlier years at all, right? So most men diagnosed with prostate cancer do not die from prostate cancer. Rather, they actually die with prostate cancer, meaning that they would pass with prostate cancer still affecting them. Okay, so prostate cancer is basically when our prostate is enlarged, because cancer is uncontrolled cell growth. So as these cells grow and grow and grow, that would make our prostate bigger and bigger and bigger, right? So prostate cancer is basically a very enlarged prostate physically, right? That's how we can tell. That's how we can detect prostate cancer. Now, there's another condition that's called a benign prostate hyperplasia. Now, what that is just for some causes and reason, normal, that your prostate gland does get bigger from time to time, periodically as it does. And it as this condition, it does share a lot of the same signs and symptoms as prostate cancer. However, this goes away. So your enlarged prostate doesn't stay enlarged the entire time. It will reduce in size slightly, right? But it will also enlarge. So it's like a cycle. It enlarge, it reduces, and enlarge, it reduces. So this happens very common for men about 40. So you might hear about an enlarged prostate. So basically that's what it is. These are just cell growth of the prostate because cell continues to grow, right? That's different from cancer because cancer is just one portion of your prostate affecting by cancer cell and growing uncontrollably. But an enlarged prostate is your prostate as a whole growing larger. Okay, so some signs and symptoms. Early prostate cancer usually have no symptoms, right? But if you do have symptoms, these can include problem urinating, right? Including a slow and weak stream, or the need to urinate very often, especially at night. Or you notice blood in your urine or your semen, or trouble getting an erection, right? Or what we call erectile dysfunction, right? Weakness or numbness in your legs, in your feet, loss of bladder or bowel control, or consistent pain in the hips, back, chest, and other areas. Now, these are some signs and symptoms of prostate cancer. However, that could also be signs and symptoms of a enlarged prostate. So sometimes we really can't tell what it is until we do a test, until we go for a screening. Some risk factors mentioned: age. As with breast cancer, as with all types of cancer, the older we get, the higher risk that we are at with any types of cancer. Also, family history, genes, our genetics information does play a role in this. Race. Now, we do know that from statistics, African Americans do suffer, are affected by prostate cancer higher than the other races. genetic mutation, something we can't control, also other risk factors associated with cancer, right? Such as carcinogens, such as smoking, right? These are something in general, all types of cancer have very similar risk factors. Some guidelines, right? So if you're average risk, we recommend that your screening starts at age 50. Okay, 50 is our recommended screening guideline age for average risk. If you have a high risk, meaning that you have a first degree relative, your brother, your father, your son, they have diagnosed with prostate cancer at an early age. What we mean by that, if they're early and younger than 65, if you have any first degree relative with prostate cancer that's younger than 65, then you're considered at a high risk. Then we recommend you to start screening at 45. If you're at a higher risk, the highest risk, you would start at age 40. And what that means is that if you have more than one first degree relative, meaning that maybe your father and your son or your father and your brother has prostate cancer before they were 65, then you are very, very high risk. Then you should get started at age 40. How do we get tested for prostate cancer? For those who've done it before, or those who knows about this, there is the traditional way, what we call the digital rectal exam. That's the method where a doctor will put on glove, put on some lubrication, and physically use their finger to feel your prostate, to feel if your prostate gland is enlarged or any issues with it. Right? Nowadays, there's a less intrusive way, and you'll be glad to hear that it's just a simple blood test. So you just draw blood from you, and that's it. No physical, feeling of the prostate. So that test is what we call the prostate-specific antigen test, or the PSA test. So you might have heard of it, you might have not. Actually, through our outreach, a lot of men have not heard of a PSA test. So that's something new that hopefully would be beneficial to learn about. So before I go to the next slide, so PSA test. So it tests for as it mentioned, a prostate-specific antigen. So it tests for that protein level in your blood, right? So with a enlarged prostate, or even if you're at risk for prostate cancer, that protein level will be increased because that protein is produced specifically by your prostate. So if you have a larger prostate, or if you have a prostate that's abnormal, that protein level in your blood would also vary. So a higher level would be will be indicative of a risk of prostate cancer. Right now, we don't have a threshold saying that if you have this level, then you must have prostate cancer. So it's all a reference range saying that you might have a high risk if you have this and this and that. So, but it's still a very useful tool for a very simple tool, right? Just a blood test. So some barriers of getting screened. We know, especially for men, sometimes without learning about the PSA test, if you only know that there's the test for prostate cancer is to, for the digital rectum exam where the doctor would have to physically feel your rectum, sometimes you might feel embarrassed, or sometimes you might feel discomfort or pain for the exam, right? But with now knowing that there's a blood test available, we might not have that barrier. Right? Same thing, right? Lack of time, lack of knowledge. We don't know what prostate cancer is, or we don't know there's a screening for prostate cancer. So hopefully today, through this presentation, through what you've learned today, and hopefully you can spread to the people around you that, there are these options, there are these tests out there that can help with screening for prostate cancer. Now, for us at Mount Sinai, we do have a wonderful, wonderful mobile unit. This is a prostate cancer screening mobile van. So it's a big, humongous truck. It's those cross-state giant bus. That's the size of that. So it's a mobile screening van where, of course, for prostate cancer screening. So they have their own schedule, or if you're interested, you can actually contact them for this number, and you can request them to be a certain event where you want them to be there for the men to do a screening. So what we do there is a PSA test. So no physical feeling of the prostate. We'll draw blood. We have physicians. We have so depending on which day is it, we'll arrange for medical staff to be there to do the blood draw, right? So that's the email as well as the telephone number. If you want to learn more about it, this is also the website. Basically, it's mountsinai.org prostate cancer screening. You can learn more about what our prostate van does. So it's been around the city. I don't know if you've seen it before, but it's a humongous blue van. You can't miss it if it's there. Yeah. All right. So now in terms of treatment, okay. All right. So treatments. Once again, I have to bring up the fact that prostate cancer is a slow growing disease. So sometimes, even if you're diagnosed with prostate cancer, a healthcare provider might say that we are not doing anything to treat this cancer. We are just going to actively doing an active surveillance, because these tumors, prostate cancer is very unlikely to harm the patient. Of course, aside from the inconveniences sometimes of the signs and symptoms that I've shared before, but in terms of damaging wise, it doesn't really affect the health of the patient that much, just because it's a slow growing disease. But for those who wish to have treatments, we would normally do radiation or a prostatectomy, meaning cutting a portion of the prostate out, or maybe the entire prostate out, depending on the severity of the, as well as the difficulty of the procedure. These are for the low and average risk group, right? So if you're at the intermediate or high risk group and we screen that you have prostate cancer, then normally it will be a radiation therapy with hormone therapy. Of course, prostatectomy is also an option, but at these stages, there's also a lot of the side effects that will come into play. Now, surgery, right? Known as prostatectomy, it's the common choice to cure prostate cancer if it's not spread outside. So we just cut off a portion or the entirety of the prostate gland, and then you're good because the cancer cell has been removed from your body, right? There are less non-invasive and less invasive treatment, such as radiation therapy, we shared before, chemotherapy, immunotherapy, hormone therapy, and targeted drug therapy. There's many options, right? So if you are unfortunate enough to be diagnosed with prostate cancer and you want to know what treatments are there, there's plenty. But your best options is to have conversation with your physician, be proactive about your health, find out what's best for you, because everyone's different. Everyone's body reacts differently to different things. Someone else's best treatment doesn't mean it's the best for you. So always talk to your provider and figure out what's best for you. Now, after treatment, right? Depending on the treatment, nearly all men will experience erectile dysfunction to some extent following prostate cancer treatment, right? Be it radiation therapy, be it prostatectomy, be it drug therapy, because our prostate is an integral part of our reproductive system. So any treatment or anything done to it, it's going to affect our, our sexual performance, right? So the amount of time for recovery is depending on the treatment. Less invasive it is, the less time for recovery. The more invasive it is, the more time it takes for recover. So it also depends on the amount of nerve damage during treatment, right? However, specifically for erectile dysfunction, we could take Viagra or Cialis or other common or other drugs that helps with that to mediate some of the effects of erectile dysfunction. Right. So I'm nearing my end of the presentation. So once again, we encourage early detection as well as be proactive about your health. Right. So when you're at the doctor's or if you're at a mobile van, right, if you're doing screening in a mobile van, you can ask the medical staff that's there, say, any advice for me based on my family history, right? As I mentioned, if you have a first degree relative that has prostate cancer, you might be a higher risk, right? You can mention hey, maybe my uncle has prostate cancer when he was 50. Should I be worried? Should I be concerned? Things like that. Should you get screened for prostate cancer, right? Sometimes you're not of age yet. Maybe you're at age 45 or 48, right? You're not there yet. Right? Should you get screened? Because with every person's risk factor differs. So that would also be a conversation to have with your doctor. Someone with a higher risk factor might start their screening earlier. All right. What test will you write for me? Can I just do a blood test, or do I need to go in for a physical test? Right? And you recommend special follow-ups. or how long it will take to receive my results, how I'll be notified of the result, right? Sometimes we just do testing and then we don't know how we're going to get our results, or sometimes we don't know what our result says. We just get a paper with a lot of medical terms on it and we don't know what it is, right? Those are the conversations that you should have with your providers, with your nurses, with the people that's in charge of your health, because ultimately it's your health, it's your body, right? So same thing. If you have any questions, you can contact us. Natalie is my coworker that specifically works with the urology department. And she specifically worked with the mobile van. So you can take a picture of this email. You can send her an email saying, hey, I've heard from today's presentation that there's a mobile van available. How can I learn more? How can I get that out to my community and do a screening, right? That the Joshua's myself, right? So that's my email. Same phone number, 824-7802. That's for our team of health educator and clinical research coordinators. You can call us and hopefully we'll be able to help you or guide you to where you need to be, right? So that would be all for my presentation. I know it's a lot. I know it's an hour of me just speaking. Hopefully it's not too overwhelming and hopefully you have some questions for me.
First, we want to thank you for the terrific presentation, and you must be exhausted.
I'm getting a little sweaty, yes.
Okay. So why don't we start with any questions? I have one, but I'll start with a. Go ahead. Okay. Mine is a simple one. First of all, after full disclosure, my son is a world famous prostate pathologist at Sloan Kettering, so I know a lot.
Okay. Yeah.
But what you put forth together was so clearly what he says now in the field. So you're right. Not to question anything, but you're right on target. You're right up to date. The PSA, I was told years ago, don't bother with it. It doesn't mean anything, and you kind of indicated that it doesn't necessarily indicate anything. But someone, not my son, but someone else said that if the PSA level is at a certain level, and then it's higher, significantly higher, that's something to be concerned about. Is that correct?
Yes, that's correct. Yes. So there is no threshold or cutoff point of the PSA level. So meaning that there is not a specific amount of the protein that we detect in your blood. If you pass this level, then you have prostate cancer for sure. Yes, it doesn't indicate a absolute. It only gives us a reference saying, yes, just as you have shared just now. If you have a higher level at the PSA of the protein level for, let's say, at this range, then you have a higher risk. If you have a normal range, then you have a normal risk. So it's just a reference, a tool to peek into what could be or what it could be not, right? So yes, so yeah, you're correct. It doesn't tell us absolute you have it or you don't have it. It just tells us, oh, be careful because you have an elevated level of this protein. You might need to go get a physical screening or you might need to do more testing. Yes. So yeah, you're absolutely correct.
Please, Ken.
Thank you so much. Really great information. Just a couple of questions. One, I've heard that people above a certain age, men above a certain age, if they have a prostate cancer diagnosis, they're just not going to do anything because of the slow growth. Is there a guideline these days for what that age is?
Yes. So yes. Unfortunately, that is the case for some individuals, especially men of older age. If they are diagnosed with prostate cancer, no treatment will be done to them. That actually, I've shared a little bit, I've presented a little bit over in the presentation, but just go into a little bit more about it because sometimes these treatments itself causes more harm to your body than letting the prostate cancer remain in your body. Right, because we mentioned that it's such a slow growing disease. It's such a I don't know if I'm using the right words, but it's such a non-significant cancer type that it doesn't affect your everyday life in terms of compared to, of course, compared to the other cancer types, right? So it's something that most men could live by, especially at an older age, that it's probably not worth it to do the treatment because it would cause more harm to your body than to let the cancer stay in your body. So I don't know if you're catching what I'm saying, because there's definitely side effects to immunotherapy, chemotherapy, surgery. There's side effects. There's always damages to your body with any types of therapy. So of course everyone's different, right? So that's a conversation that you should have. Everyone should have with their doctor, saying, okay, I have prostate cancer, right? For example, but I'm also 75, right? What are, how much is this prostate cancer going to affect me? Should I do a surgery or should I do a treatment for it? Or is the treatment going to cause me more harm to my body, right? So yes and no, right? So it's something that everyone's different. You should talk to your healthcare provider, see what's best for you, right? They might suggest that you go do a treatment because your cancer is affecting maybe your urine, your bowel movements or things that would affect your everyday function, right? Some people's prostate cancer might not affect them, right? So it's something varies by person.
Okay. And I assume the van, you don't need insurance?
Yes, the van. So the van we do require insurance. So if it's that you could send me an email. I could figure out or you could send my coworker the email, Natalie. If you want it, I can show it back up. So you can email them or email the prostate van email to make sure that which insurance they accept. They accept almost all insurance, but of course that's something to make sure before you actually go. Yeah.
Okay. And on the low incidence of male breast cancer, I guess obviously you wouldn't get a mammogram. Is there a way to test for that? And what are the symptoms?
It's very similar. Actually, yes, you can get a mammogram for a man if it's needed. So of course, it's you would have to come with a referral from your doctor, because they won't just let you without any plausible reason to do a mammogram for a man, right? So with a referral from your doctor, men can do a mammogram. Also an ultrasound or a biopsy. So there's many different options for men to do testing and screening for mammograms for breast cancer as well. Yes.
Thank you.
Please.
I have two questions that pick up on two of Ken's questions. One is about I lost you. There you are. One is about the mobile prostate van. Is there a similar van for the mammogram?
Yes, we do have a mobile mammogram van, but the details I am unfortunately not very familiar with. So maybe Brad might know a little bit more.
I was going to say, if you have any questions or you're looking for an organization, you can reach out to me to try to help you. I can also help you with the prostate van too, but I'm just saying, either way, I'm happy to help, with either grouping.
Yeah.
Okay, thank
Reach
you.
out to Brad, yeah.
Much, Brad. So we can follow up with you, Brad, about the mammobile.
Yes, or the prostate. I mean, as well. Either one, I can try to help you with this.
You would
Okay.
work for the same place.
Okay. And then my other question, getting to the screening issue, is the news that's been made over the last couple of years about the breast cancer in women with very dense breasts, where you either get the false positive because you have the dense breast, which you did touch upon, Joshua, but also the need for some women like Katie Kirk, of course, comes immediately to mind, to need that secondary, I'm looking at myself, to need that secondary testing method with the mammogram, for example, a sonogram. Can you speak to that at all, and whether insurance covers that?
Yes. So most insurance do cover for dense breast women. They do cover the additional diagnostic, screening imaging that they need. So yes, they do cover it.
Okay,
Just
so
to give
that's
you a little. I have a colleague whose mother had breast cancer. she has very dense breast tissue. She almost always had to go for the secondary test, and the
Okay.
insurance covered it as well.
So is that becoming, either Brad or Joshua, becoming more typical or more part of pardon my lack of medical knowledge, part of the protocol that's accepted for women who do need it to be able to have that secondary test?
Yeah, I mean, Joshua can speak to it more. I mean, obviously, in the end, if they can diagnose it earlier, it saves the insurance company a lot of money. The cost of a sonogram is a lot cheaper than the treatment for breast cancer over the course of time.
Yes.
So
Okay.
hopefully that's the way we're going.
Yeah.
But,
So
but you would need the referral from I would think your doctor would need to say this woman is gonna need that sonogram.
yes, that's absolutely correct. So after your first mammogram, right, or if you've done the mammograms before and you've been going to the same place where your doctor or your technician knows that that person has a dense breast and would likely require a second one, they would do the referral, and that's the issue with insurance and the doctor. I'm sure they will figure it out, right? But for insurance policy wise, if for women with dense breasts, as indicated by doctors, they are covered for additional screening procedures. Yes.
Great, thank you so much. Really appreciate it.
We were
And
told.
we are noticing a bit more because good thing is more women are doing these screenings. So we are noticing, more and more dense breast, cases are popping up. Yeah, for sure.
We were told with lung cancer screening that at a certain age, after a certain age, they will not do it. Is there any age limit for any of these?
Yes. So we do have, but I think but it ties into a similar issue that I've shared with before with the gentleman sitting just 2 seats away from you. So at a certain age, even if we find cancer, that it's probably more harm to your body to treat the cancer than to let the cancer remain. So of course, sometimes it's, once again, I'm gonna sound like a broken record. Everyone's body is different. Everyone's, a medical a condition is different. So it's always a conversation you should have with your provider. But in terms of screening wise, yes, breast cancer, I believe, goes up to age 75. After that, you're no longer required to do annual screening. Of course, if individuals still want to do their screening, they can still do it, but insurance don't cover it after 75, I believe. So after that, it will be out of your own pocket. For lung, I think it's 80. For prostate, I believe it's also 80 as well. So there's a point at which even if we find cancer, it's probably not going to affect your estimated lifespan or that much, right? To necessitate the need of treatment, if you're catching what I'm saying. Right.
Yep.
Mhm.
Okay, are there any other questions? I'm motivated, and I'm going to talk about this afterwards. Maybe we should have a cancer screening activity sponsored with our committee, the board, and Mount Sinai and other agencies, because I think there are so many people who are not not actively looking into these things. I have family members who, check the BRCA.
BRCA gene, yeah. Mhm.
Just now, after 10 years of avoiding it. Unfortunately, there was no issue, but early screening makes a big difference.
Yes. All the statistics shows that the earlier the screening it is, the earlier that, even if you have cancer, the earlier you find, you have many treatments available, versus if you're at a later stage 4, there's not much we can do by that time. Yeah.
I'd like to look into more about the uninsured, because we have many people in the community, particularly the poorer people in the community, who don't, even if they have knowledge that there's a setback. I dealt with someone who could not get treated
Shelley, also remember, we have programs to help people try to get insurance and see if they qualify for, Medicaid or Medicare and stuff as well. So I put this in, I'm putting this in a non-political way. The very poor should be able to access insurance. It's the almost working poor. There's a level of, people who are the working poor might have more issues, but even that with the ACA and that, there's usually ways to help people get and find insurance, and we can help with that as well.
I'd like to point out that the Heal Center
Right.
at Mount Sinai, Morningside, I brought someone there who was not being treated otherwise, and they're in the process of getting the Medicaid. So
Yeah.
the system's working.
And Sinai has a similar program. They had, we just kept the names of each one when we merged, but Sinai has a similar program to help people as well get qualified for insurance.
I was actually sent there by Morningside.
Okay.
Okay. Seeing no questions, are very deep and strong appreciation for this presentation.
Thank you.
It was comprehensive. It answered a lot of our questions that we don't even have to ask. And
That's good. That's good.
now because of that, and we look forward to being in touch for follow-ups, things that'll benefit the community. Thank you so much.
Thank you. Thank you for having me.
Have a good night, guys.
All right. Good night. Thank you.
Okay. We're good. So, any thoughts, any other than my enthusiasm about doing something, getting all the mobiles that are available?
What disturbs me is the idea that at 75, we may not be able to get insurance to cover it.
I called my doctor prior to the lung cancer screening. And he said, one, I didn't have enough family history, all these things. And then he gave some age, and it was 78 or something. He said, we don't screen after that. I said, what if a person's willing to pay? And there's still reluctance unless they felt you had a family history or symptoms or so on. And that was disturbing too, but an age limit, it's
I will be asking my
Yeah.
doctor.
in 25, 30 years, we'll all have to be concerned.
I guess it's just one more
No, I
year.
know.
One more year and I won't be able to do it.
Okay.
What they said.
Mhm. So you thought it was 50? That was the.
I thought it would
I know,
go on.
I know.
Should be, yeah, it's like, life insurance is like,
Uh-huh,
you're covered up to a certain age. That's it.
yep.
And then after that, you're on your own.
So let me ask two questions. The first is, would the committee be interested in being a sponsor and arranging for the mobiles and maybe some other things to help them?
Definitely.
Okay, that's good. And the second is, in terms of next month we're doing, and Eddie mentioned the
Compost.
composting.
I have two issues, but that was one.
Okay, and we could have someone to speak about it. Okay,
Yeah. Yeah.
maybe not from Sean's office, but
It's not urgent. I did a little poking. I'm sorry, I didn't mean to interrupt.
A
Go ahead.
little
I did mean to
a little
interrupt.
composting or
A little poking.
okay, so why don't you share it?
So what I learned, which all of you probably already knew, but we're not due to be mandated for composting for another year. So a year from October, a year from this month.
Right.
But maybe we do want to get ahead of it. I brought it up because I've been asked about it by so many people. So I don't think it would hurt to have someone come speak.
Definitely not.
We could do it sooner, we could do it later. We certainly don't want to wait until it's upon us. But that is why I brought it up, because the
I
number,
think it's a great idea.
sorry to be,
The,
And I think, and I know a lot of people who are. interested.
on 97th Street, there's a farmer's market. I don't know if all of them do, but there's composting, there's a composting station
Mhm,
every Friday.
very nice.
People,
You've probably noticed the orange. Have you noticed the orange trash cans around? Yeah. I don't know. 30
Notice the
of them.
brown. I don't think, I know that I've noticed the orange.
Orange ones, yeah.
I thought it was for Halloween.
Yeah. But they need an app to open them. You have to
Mhm.
download the city's app,
Mhm,
and they take compost. That's the reason for them. And
mhm.
the reason you have is they don't want anybody just throwing cans.
Right,
in.
right.
yeah,
But also we should remember that I used to be on the Parks and Environment Committee,
Mhm.
and they're probably, if we ever did anything on it, we should probably join with them.
Mhm.
'Cause I think we did have a presentation a number of years ago about compost.
Well, and I guess my question when I emailed about it was whether it would be also a housing committee question,
Mhm.
because the buildings will be required to compost.
Yeah.
So I didn't even know if it should be us or if it should be housing, but you're right about parks. So, yeah, and environment. So I'm not sure, maybe it's just a big board meeting.
You know, I'll bring it up with Beverly and with,
Okay,
and with the office staff, you know, with Matt. And see what they think,
Mhm.
but it's certainly something I think would be high interest. And.
Yeah.
Yes. Yeah. You think so?
Oh, yeah,
Okay, anything else?
Yeah, I have a friend that they do composting in her building. She has like these little green bags
mhm,
that you have to, and they sell cans, little cans that put your food in.
yeah, we do it in our building and it's so
Yeah.
popular that the president of our building wants to get a second bin. You get them from the city and she wants to get a second one. And I don't know how to she came to me as if, because I'm on the committee board, I can just
We know
get a second bin. But it does show that people, if you build it, they will come. I think people are interested.
And also, just out of curiosity, what would the process look like to just have more composting bins, recycling bins on the streets, not attached to any buildings, it's more widely
Yeah.
accessible? bins?
This is what I think Ken is talking about,
Yeah, I think that makes maybe more sense.
so that anyone can,
Yeah, so if you're just walking along the street and have a
A
cardboard
banana
box,
peel,
you don't
right.
have to throw it out.
Right,
You don't want to
right.
do it.
Yeah.
Mhm, yeah.
Any topic of particular interest that people would like to see us cover? And you could always, keep developing different things, but if there's any topic that you say, well, that's what I want to know more about, or I think this would be useful for the community. If you can't think of it now, just send an email, send it early. And we can do something. This was interesting because normally Brad's able to bring out someone right away. And one is the person who was the clinical research facilitator in the Icahn school at Mount Sinai, and got the person who does the research. So it's fortunate, but the earlier we get the topic, the easier it is. And normally we'll meet with the person, discuss the things to make sure it's not too long, not too short. Maybe it's more on target of what we want. We're not, and we have to adjust it. And,
I know we've touched on this before, but the noise issue. I don't even know if it belongs to us.
okay.
I don't know.
It was put on to us
Yeah,
because the person who wanted it most, Benjamin, wanted something done, and he figures we get things done. So
well, I mean, I don't know. I mean, it is an issue though.
we can bring it back because There is active legislation at the city council, okay? It's strongly
Wow.
supported. But then it lags, then there's nothing happening for a few months. So, and Gail Brewer's involved with it, and what's his name from the east side, he's the majority leader or whatever it is.
Keith Powers.
Who's that?
Powers.
Yeah, Powers. He is very active and done a lot of things on environmental issues like that. So it's certainly active.
Like right now.
Exactly, and day and night.
Oh,
And poor Benjamin lives in a place where it all comes to him. And I have stood on corners when there is no traffic going on.
And there's so
Okay.
much.
And they're not coming to something, they're coming back from something. And we learned some information. And it's a big question, why fire trucks, the ladder trucks,
yeah.
follow them when there's no fire. And I don't want to cast aspersions, but the suggestion was that in order to keep the level of fire mobile equipment, they need to have a certain number of episodes that they respond to. No, they're responding to. So they need to respond to enough to keep.
Wow.
And now I heard this from someone who was active in the area, and but that's really not the goal. The goal is to reduce the.
Well, and I'm gonna tell you, Shelley, and I don't know, it may have to require maybe a study on all transverse. I don't even know if these ambulances or fire trucks are traveling with knowing, well, if there's an emergency, why would anybody want to go through Central Park 97 with all that congestion? They'll never get through. I can't, and it seems to me they may be following a GPS. They may not know the street, because anybody who knows the street would know.
You don't go through there. Right?
Well, I mean, not if you really want to.
An emergency, right?
Yeah, we have the farmers market. God forbid it's on a Friday.
So we're talking specifically about siren noise.
Lots of siren. Well, yeah, specifically siren noise.
Siren noise from emergency vehicles, and it mainly where we understand the need for it, but there are certain decibel levels that
Yes.
that they're on that are unnecessary. They can have the same effect. There's also the issue of if there's no traffic ahead, why are you making all the noise? The noise we think is to alert people ahead, on the street that someone's coming. So there's maybe need for some silence, pedestrians and so on.
I mean, and then with the you have also, like for me on 97, I have Whole Foods that every night they do their delivery, and that truck is in front of, and they're there until, I don't know, they're waiting. I don't even really know what they're waiting for, but they're there and their truck is on, and then they back up. And I mean, it's pretty impressive.
And one thing we found, this stuff that we found, we had a resolution from the committee. And I'll pull it up and send it out to everyone. The health effects of the noise, okay, are definitely clear. That there are definite connections with a number of health issues, and so it's not just the noise, which is annoying enough and affects the quality of life and disturbs people. I remember when I was 8 years old, we lived by an elevated train, and when I was younger, we lived in a residential neighborhood in the East Bronx. Okay, then we moved to the West Bronx, and I got a tape recorder, so I was taping something just for the fun of it. And when I played it back, I heard noise that I didn't know was there. I had become so accustomed to hearing the trains go by and the noise in the street that I wasn't even aware that it would be interfering with what I was doing. So you can become accustomed to things.
Oh, yeah.
but sirens are.
No, you do become accustomed to your, but if you're hearing it,
Yeah.
when you're hearing it and it's various,
By the way, my wife gets annoyed with me sometimes because she said, "Did you hear that?"
you're
I
like, what?
said, "Did I hear what?" And she said there were sirens. And I said, "Sure. Well, what else is new? It didn't stop by our house."
Well, I think if noise is part of our
And it
jurisdictional, that's not
because
the
it's
right.
a health, because
Yeah, understood. Or environment, maybe with parks and environment, then we should address it and then perhaps break down which noise we're talking. I live right across from essentially a very noisy facility where there are ambulances 24/7. And I grew up on the FDR Drive, so noise is not my issue.
Mhm.
But if we're going to address it, we need to break it down. Sirens, police sirens,
Mhm.
fire sirens,
Emergency.
delivery trucks.
I mean,
delivery-
even though you
So this
is the west side falling apart? I
no,
mean,
it's the
wow.
I'm sure it's the same noise it's always been, but we need to educate ourselves about why the noise is there. Do the decibel levels have to be what they need to be?
Right.
We need to have people come in and explain it, or we need to push back against it. I'd love to see that resolution.
Sure. Mhm.
But if we want to put it on the agenda, we should do
Okay.
it.
Let me just add something that we would really have to do a study, stand on a certain corner
Mhm.
and say, 10 fire trucks went by, 3 ambulances. went
Yes,
by,
that's a good idea.
Yeah.
That's right.
And the decibel level, you're right, it's very.
Okay.
At the 24th precinct last week, there was noise complaint.
Well, the
And,
other thing
it's not
too,
fair to complain to them because they were not going to,
it really, maybe in my,
I don't think. it's fair
I've
to
become
complain.
hyper sensitive to the noise. We have PS 163 is also under construction. And they start at 4 and they end at midnight.
There are no children going there.
Yeah.
There are children.
Yeah, the school's open, but the guys start work at 4 when the kids are gone. And they don't stop
Yes.
till
Yeah.
12 or 1 o'clock in the morning, overtime.
And there must be regulation.
Wow.
Okay.
No, you're not supposed to honk your horn, but nobody pays attention to that either. So I
Yeah.
think we should put noise on the agenda. We've got compost. I think we should put rats on the agenda.
Okay.
Everybody's favorite topic. So
Well, the
we've got-
rats, that's gonna get
Maybe we
mitigated.
can invite some, talk about their perspective.
The
Containerization.
compost and the rats go together,
Oh, yeah, they do.
Containerization.
but a lot of my
But those-
neighbors ask about the rats, so I'd like to give them some answers.
Okay.
The compost is a solution to that, though,
It's a solution.
not the solution.
Yeah.
Well, and the containers aren't, I don't know, aren't we
How,
supposed
how
to?
widespread and
With the
how
trash.
small businesses were just.
So which one are you gonna tackle next time, Sheldon?
Okay, I'm gonna look at what's possible to get people to speak us
Okay,
but taking those three into consideration. What, will we get new information or worthwhile information where we can advocate for something? Because if we hear and we know now this is what's going on, we don't have any way to advocate for it, then it's more frustrating, because now more information
right.
and still nothing changed. And the
Mhm.
committee traditionally did things and advocated for things, and many things we've done, particularly at the time of vaccinations and so on, where 10025 was considered a middle class district,
Mhm.
4,000 people were in NYCHA developments just in that area, largely Douglas houses. And they couldn't get it because they were 10025 and they were doing it by zip code. So we ended up getting them. And the-
One thing, and I
Sure,
don't mean to be
please.
disrespectful.
No, please.
I have to get a health treatment tonight, so I have to leave.
And we are going to leave in about 2 minutes.
Okay, well, I have to head out. I have
It's
time,
o-
but lovely meeting.
Okay.
Nice to
And
see you.
and basically, we used the roundabout way. We went on every Friday, went on the citywide thing, and they all agreed with what I was saying, and they did nothing about it. So we did two things. One, my housing organization, West Side Federation Students for Housing,
Mhm.
has a senior center there. So we asked the city to do a senior thing. And so then we had that.
Mhm.
And then Governor Cuomo was in trouble at the time. So he responded to getting in the tenants center there. The state would do it, and that was going to be for younger people. The only problem is we couldn't get the younger people out. So we sent the seniors to get to their nephews and grandchildren and everybody, and they went around knocking on doors, and we ended up one morning getting 19 or 20 kids who were sleeping at 10, 11 o'clock in the morning to get out, and it ended up successful. And they said they'd be there for a week, but then how do you do the 3 weeks afterwards? You know, when you needed so it was going on for about 2 months, you know, in there, and we had signs up with the, you know, like, what are they called? What the people advertising restaurants,
Billboard.
like the
Sandwich boards.
sandwich boards, right? We had them out on the street, we had people walking around with them, and it worked, but the city had this interesting perspective. We'll do it by zip code. So if you're in a zip code, you don't get any discounts. Okay, because you're poor, and then you can't get service because they're around other people who are more middle class. It's been historical, going back 20 years, this constantly happens. And Amsterdam House, it gets it worse, because they're a small population, and they're more wealthy population. So, and yes, please.
I just had one idea of a topic, or at
Right.
least something for our discussion. That, you know, I don't sit on all committee meetings, but I don't know if this topic has been discussed. But of ways of supporting obviously, we live in a predominantly Jewish neighborhood, but ways of supporting our neighbors of Jewish faith since the unfortunate events that's happening in Israel and Palestine. I want to know if there's ways to help support the faith. That if for whatever reason, if they feel unsafe heading to their synagogue, if we can find other places where they can continue worships on Friday nights. I know my Catholic church is very open to lots of things. I don't know if they'd be open to supporting that. I'm not going to speak on their behalf. But I just want to know if we can continue to help.
I think we'll do it in 2 ways. The first week, the police precinct sent people out, you know, and there were people, you know, there were not too many police, but there were a lot of police a lot of the time. And now it's 51% of the hate crimes in the United States are against the Jewish community, and there's only 2% of the population. Doesn't look like it on the west side, okay, but that's reality. So that's and there are significant percentages of other groups, but this is 2% and 51%. So appealing to the police precincts to provide coverage, because my synagogue got a hate letter. Okay, and the leadership did not want to share it, not to scare people. But I told them, I used to be in leadership, but not now. I said, you need to go to the precinct, you need to contact the VA's office, you need to do all that, and make sure and then follow up. Because one, you know, it's not going to take 50 people doing something wrong, it's going to take one person doing something wrong. And it's still in fear by a hate letter. You know, they should be able to. So what could people do? The best thing, as a Jewish person, suffering with a sister, family having rockets going over their head, and a nephew, a best friend, just flew over to help out because they have medical training. So that is a little kindness, you know, a little, you know, assume that if someone's Jewish, they're going through, you know, I'm so sorry about what's going on. You know, and just person, because it makes a difference, you know, and that's what can advocate in the church too, you know, because you have to assume that people are going to. I know people who whose affiliation is that thin. And they don't want to go out, they're afraid of things, they're constantly watching TV. I said, stop watching TV, you're gonna get upset. I think that's the best thing to do. All the politicians are doing that thing. They all check their body. They made a good
Did
speech.
your leadership take your advice?
I'm not sure, but I called and I found out that the precinct knew and they were taking it further. It's ridiculous because I'm on the community security service. Okay, volunteer, and so I can contact people all over the country, and they want to know what's going on. But this is an interesting group. They do very good work, but on this, they made a decision not to let people know, and I think it's not right. Okay, you can use your judgment, but you have to let people know that it's a credible threat because we received a letter, and that we're doing the ABCD for security. The one thing they are doing, I'm certified with this community security service, this volunteer. And we have no one else. We have all these young people. We've got 500 people coming and no one has volunteered. So this week they finally said, we're going to try to get people trained now. We want you to sign up. We're doing a campaign. We'll see what happens. But I've had people come in who look suspicious. Okay, because they walk in, we've never seen them before, and they sit down in an area where no one's sitting. And I go over and I say, wishing them hello, and they don't want to say hello. And then I see they don't have a prayer book, and I go and get one. I said, this is the one we're using. Well, like that. And then what do? Then I go to the security, we have a security guard. I said, the guy who walked in, yeah, I thought of this one. I said, when you think something's funny, get myself or someone else, we'll talk to him on the outside.
Right.
And we ended up doing that.
Yeah.
And he wouldn't give his name. And he wouldn't say why he was there. And he said, but I can be wherever I am. I said, that's not true. We want to greet you. I tried to greet you. You don't have to be friendly with me, but you have to tell us who you are.
Yeah, these are really bad times.
Right? And this is anytime,
Well, that's true.
And why you're here, because what I learned in my training is that sometimes people come to check out the place. They're not there to do anything that day.
Of course, yeah.
But they're seeing where people sit, how many people are, where
They're sizing it up.
sizing it up.
Absolutely.
And it ends up, he didn't want to even share anything, like why he chose to come here this morning, because you live in the neighborhood. You don't have to give your social security number, just a little something. And I just said to him, I'm sorry, you won't be able to.
Well, and it's not the sidewalk. It's not like he has a right to just sit there.
Yeah. And I tried so hard. I asked 15 people, do you ever see this person before anything happened?
Yeah, no.
And no one knew him.
No.
And there was just something about him that looked suspicious. I'll tell you what it was.
Sad.
This is, I thought, what's wrong with you? He was tall and thin and he had a mustache without a beard. And most Jewish people with Orthodox spend, if they're going to have a facial hair, they have both. He just had a mustache. And you know what a mustache means to me? Historically, who had a mustache and not a beard?
Card table?
Oh, that would be nice. Someone.
Some guy named.
So, yes.
It's some guy named.
So I said to myself, stop it. But then I said, don't assume anything. But he did everything wrong. Okay, and he wasn't praying.
You're right about the mustache. That's an interesting
It
historical.
just was, and it was also something different than everybody else. And I don't know anyone who just has a mustache. So, I said, but that's terrible.
Well, it wasn't
What if
just
he
that. You spoke with him and he didn't.
Okay, I didn't leave like.
Yeah, no, you spoke with him and he didn't interact.
Right, I tried sending other people over, who looked more his age, and he just didn't know how to communicate. But the fact that he came in and never took a prayer book of any type. We have translation, we have
Yeah,
everything.
no, it's not right.
It was wrong, and he never came back.
Well, especially given what's going on,
Exactly,
right?
yeah.
Mhm.
Now, this was, we have, fortunately, I got a grant a number of years ago, so we have surveillance cameras. So we have, you know who he is. So
So sad.
we gave his picture to the security, to the police, you know, so on. So that they see the guy. Now, could he be innocent? Yeah, he could be a person who is not, you know, is antisocial or, you know, I have a right to do whatever I can do.
Right,
whatever I
don't
do.
ask me questions.
Yeah, right. Who are you to ask me anything? It's a free country.
Right,
And so but I think the general answer to the question is acts of kindness. Okay, and concern.
But I think we want to protect everybody.
Of course.
And, you know, the only act of extreme violence I can think of in this country related to this was the little Palestinian boy who was killed by Palestinians. And there was an article in the Times about a restaurant in Bay Ridge, a Palestinian restaurant that's been getting letters and getting terrible reviews all of a sudden on TripAdvisor.
Yeah.
And 10% of the hate crimes are Islamophobia.
Mhm.
Right,
Okay,
right.
so that's true. But-
Well, we all remember what happened after
Yeah.
9/11. Yeah.
So anyway, it's.
But the issue with this, and that's what's so wrong, and it's giving, you know, it's opening up the whole, you know, beneath the surface anti-Semitism, Islamophobia, and so on. It's running generally by people who are not directly affected by what's going on over in Israel and so on. And as I tell people, you know, this is not an anti-Palestinian thing. This is a terrorist group who came in and did a horrible thing. And those people were concerned about, everybody should be concerned about anybody who, the 1.4 million Palestinians in Gaza who have no control of what goes on in their lives. They weren't allowed out. They don't get the food over the humanitarian aid that they always get. They're being controlled by a terrorist group that's in political power. And not that everybody from original Hamas, which was a political movement, is going to be a terrorist, but there are a lot of terrorists doing terrible things. So it should be an anti-terrorist thing, which I think everybody should have, you know, feeling for, you know, anywhere. And I think everyone should condemn the killing of the boy or anything where people are being targeted who are not terrorists and who are not doing anything just because of their national identity or race or religion. And it's really important. And what I've been talking, because I'm in education, I've been talking it up online and other places, how we have to talk to the kids about how to distinguish between one thing and another, and to hate actions, but not people. You know, not groups of people, because they're bad actors. Because every group has that, except for Dominicans that are all nice. No, I always tell them, you know, but really, that's my thing, because I've never met someone in Dominican who was really nice. But I said that's ridiculous. Also, there's got to be, you know, bad actors and everything.
Yeah,
of course.
Yeah,
and good.
and plenty of good.
And good.
But I think that's it, because otherwise, everybody's going to find their way. But the concern is, what are my neighbors? You know, who are my neighbors? You know, don't they realize that I must be feeling bad? You know, and if they, for some reason, some part of their identity was being challenged, and wouldn't I right away go over and say, you know, this must be so difficult for you, and I feel, because that's humanity. Okay, so to meet the inhumanity with more humanity, you know, in the circles that we go, and with the people we know. It's so on that, everyone sign?
Yes.
Okay,
So,
and we thank Simon,
Thank you.
Okay.
yes, we did.
okay, because we didn't have any technological problems.
No.
Yeah,
Simon looks like Eric Stone.
sorry. And we thank Alex.
And we thank you,
Okay. Okay.
and we thank, oh,
Hi,
yes,
Alex.
hello, Alex.
Thank you.
Hi, I'm
No problem.
Alex in the other room.
Wow.
Because it's like the Wizard of Oz controlling.
Yeah, it is. It is. Thank you, Alex. See you,
I'm gonna leave the.
See you tomorrow night.
sheet on the, in the front.
maybe tomorrow night.
Okay. I
Did
should
you
leave
do
it-
a motion to adjourn?
Is there a motion to adjourn? All in fa-
Second.
Okay, all in favor?
Aye.
Aye, opposed? Abstentions, ineligible?
I'm ineligible. I'm biased.
Good night.